Good evening and a very warm welcome to the very popular Master Techniques. This is the last episode of this webinar series this year, last but not least. We have a very exciting topic, supramalleolar osteotomy, its role in ankle arthritis, and it's something which is, I think, very important because it's not utilized to its full potential in the UK. I'm Maneesh Bhatia, foot and ankle surgeon in Leicester, a member of Education Committee of BOFAS and Scientific Committee of EFAS. On behalf of the Education Committee of BOFAS and IT Committee of BOFAS, I would like to welcome you all. Today we have two very distinguished speakers from Germany who are going to share their vast experience with us on this very interesting topic. Before we kickstart, just a few housekeeping announcements. The two speakers will give their talks, and then we'll do discussion for about 15 minutes at the end. And you can post your questions through the Q&A function. The chat would be disabled. It's important that you post your feedback, and you will receive a link to your email, and you can put your feedback, and you will be awarded the certificate for attending this webinar. We will also put the QR code and the code for you to provide the feedback just towards the end. Without any further delay, I would like to invite our first speaker, Professor Christina Stukenborg-Colsmann, who is Chief of the Department of Foot and Ankle Surgery in Hanover Medical School. She is the President of German Foot and Ankle Society or German Foot and Ankle Association, past council member of EFAS, and current colleague member in Scientific Committee of EFAS, has over 240 publications, and she's going to talk about the indications and planning for the supramalleolar osteotomy. Over to you, Christina, when you're ready. Christina, you're muted, and you need to turn your video and audio, please.
So I think you should hear me. Is this correct?
I can see you. Yeah.
Okay, perfect. So it's a pleasure for Christina and myself to share our experience we have gained here in Hanover over the last few years, and it's a pleasure to join your webinar. We have the same series in Germany. This is my disclosures, as you can see here. So as you already said in your introduction, there are treatment options we have today treating ankle osteoarthritis. And today, maybe we focus a little bit on frontal plane deformities. So that means varus and valgus deformities. So today we have these patients with you can see here in the upper right side. And the question is, what treatment can we give this patient, or what options do we have today? And this is our topic. Yes?
Can you please share your screen? I can't see it.
Okay, hold on a second. So. Try again. All the testing.
It's all the technology, isn't it? It will come. Yeah, brilliant.
Okay. Try again. So once again, you see the treatment options we have here. And the question is now today how we can treat these patients. So the topic today, as you can see here on the left side, is supramalleolar osteotomies you can do. Of course, in this technique, on how we treat our patients, we would like to describe today. Of course, we have arthroplasty with mobile or fixed bearing. We have arthrodesis arthroscopically, and then we have arthrodesis open in the open technique. So the topic today will be supramalleolar osteotomies. And this is how we are talking about stage adaptive operative therapy, because we have as treatment options the arthroscopy, the debridement, cartilage repair, and then we have the osteotomy. And also sometimes we can combine these joint preserving techniques. And of course, on the other side, we have the joint sacrificing techniques, as we all know, with the prosthesis and the arthrodesis. So what is the aim of frontal plane correction with supramalleolar osteotomy? It's realignment to redistribute the eccentric axial overload, pain relief and functional improvement as long as possible, slowing the joint degenerative process down, and maybe realign before the total ankle arthroplasty has been done on arthrodesis. You can combine these two techniques, or you can do it as a preparation and maybe add these techniques years or decades later. I think talking about these techniques, like the modern kickoff, I would like to call it, was maybe done by this paper in Takakura. We all know osteotomies have been there since decades, ages. And of course, before we had arthroplasty, there was only arthrodesis or osteotomies. But I think in 2006, this paper came out, and with Takakura, he also came out with this classification, stage 1 to 4, and he treated patients with a supramalleolar osteotomy for ankle osteoarthritis in stage 2 and 3A. And he did this because of failed conservative treatment. And his aim was the medial distal tibial articular angle, called, as you can see here, MDTAA, was below 85. And you can see here the range of the normal. And this is always, when we're talking about these supramalleolar osteotomies, very important to keep in mind what's normal, what's pathological. And you can see here the normal value with about around 92, 93 degrees you find in the literature. So when this came out, the classification came out. And you can see this here, the classification with grade 1 to 4. We're starting with grade 1, no narrowing of joint space, but beginning subtendral sclerosis and osteophytes. Then in stage 2, we have the narrowing of the joint space on the medial or lateral side. In stage 3, we have the loss of the medial and lateral joint space on contact of the subchondral bone. And the stage 3 is divided into 3A, you have a contact on the medial malleolus, or 3B, you have the contact up to the middle of the talar dome, so an increase of the osteoarthritis. In stage 4, it's the total loss of joint space, and I think we all know this is not the indication for supramalleolar osteotomy. So probably this technique is applied, as Takakura in his publication 2006 says, between stage 2 and stage 3A. And of course, when you go really deeply into this, maybe, how can we treat stage 3B? But I think if you start and you are in the beginning of these techniques, you should start with a stage 2 to 3A. The predictive value already Takakura looked at, and also later Nicolas Krähenbühl with the numbers and the procedures of Beat Hintermann. And we all know that there is, when you look at the stage 3A, there's a predictive value age and the stage. And you can see here 3A, you can even get better over the years. If you correct it, we see, like an upgrading in stages. But if you look at the results of 3B in both publications, you can see it's very unpredictable, because you have a big variation, as you can see here. And also some worsen or stay the same. So there's no improvement in terms of clinical outcome and stage of osteoarthritis. So there seems to be, the borderline we probably shouldn't cross with this technique in stage 3A. So why we are convinced, Christian and myself, and maybe some others also, that this might be a technique in the treatment options for ankle osteoarthritis, And I just picked out this one paper, and there are lots of paper, of course, from Beat Hintermann and his group, and Knupp and Alexei Bach and Nicolas Krähenbühl latest, as you can see here, in 2019. And they looked at a lot of like varus, valgus, mid to long-term results, post-traumatic valgus deformity. And I think if you are really interested in this technique, you should probably look at this too. In our biomechanical lab, in the past, we looked at the stability, how thin can these plates be, how large they have to be, what stability we need to fix these osteotomies. And then we, gave a little overview of the literature last year, but it's in a German publication literature. So this publication from Nicolas Krähenbühl, looking at the mid and long-term results of supramalleolar osteotomies, it's one of the largest group we have in the literature. So you see here, we have valgus angle treated 195, and we have varus angles 99. You can see male, female, side, body mass index. It's in Switzerland, it's very low. You can see here the age, it's in the 40s and 50s. And then you have the stage Takakura on the bottom here, and you can see most of them are stage 2 or 3A. The technique here was done in these patients. But this technique, it's not just like a supramalleolar osteotomy. You can see this in this publication here. There are quite a few techniques, of course, you add to this procedure. I mean, you are dealing with an instability. You have to combine it with a calcaneal osteotomy. You can do subtalar fusions for correction, peroleus longus to brevis transfers. I mean, there are a lot of techniques we will look into, and Christian will show us later on we have to do in these patients. What we also can see here, and this is results, and that's convinced us that this is one option with the right indication. We can, treat our patients. You can hear the risk of failure. As I said, Takakura 3B, there is a borderline. The age plays a role also, of course. You can see here, this is treated younger patients, like 50, 55. The revision rate was 12.9. I think this is important to give this information also to the patient. That means progression of osteoarthritis and then later treatment. And as you can see here, all of these like 298 patients, like 30 got a total ankle arthroplasty and 8 got an arthrodesis. So this is a 12.9%. We had a survival rate of 88% overall, looking at valgus and varus deformities with techniques in an average follow-up of 5 years plus 3.7 years. You could also see if this revision rate really fits into the literature we have today with results of these techniques. And you could see here these 12.9% after 5 years really nicely fits into the literature, as you can see here, that came out for mostly varus ankle osteoarthritis. And you can see here, this is something, of course, the patient has to be informed about. But what you can also see, Krähenbühl, the group of Beat Hintermann with almost 300 cases is like the biggest or largest group we can find in the literature. And we all know there are some Asian papers and Chinese papers that really have like large numbers too, and looking at these techniques. So what else did they find in their comparison here? So they could say that the varus deformities initially have more severe deformities than the valgus, the post-traumatic ones. And in the early years, they have a higher revision rate. So this you have to keep a little bit in mind if you look at varus and valgus cases. As you can see here, these are the pictures out of the publication on the left side for the varus. As you can see here, the supramalleolar osteotomy opening at the valgus. And as experienced, and you can see here in Hanover is a little bit different because the valgus mostly are post-traumatic. And the varus, it's also post-traumatic, as you can see in one paper of Victor Valderrabano in 2006, because this is more like an instability, supination trauma, and like years to decades after, you can see the varus instability and osteoarthritis. And what we can see here in the post-traumatic ones, it's more trauma, deformity, extra-articular deformities we have to treat with these osteotomies. In Hanover, in our clinic, we are a special orthopedic department. So it's a separation between trauma and orthopedic in Germany. So we see more varus ankle than valgus deformities. So we treat more varus osteoarthritis with supramalleolar osteotomies than valgus osteoarthritic cases. So what are our indications for supramalleolar osteotomy? It's acquired or innate ankle deformities. It's like, it could be post-osteomyelitis, like decades before, clubfoot trauma, as we said, also like decades instability that ends up into a varus osteoarthritis. It is an asymmetric ankle osteoarthritis, and it should be about 50% at least of the joint space left. And of course, lots of these patients, they have an unsuccessful therapy of osteochondral lesions with deformity. Sometimes we do it as preparation for total ankle and arthrodesis. What are our contraindications? Of course, stage 4, as I said, stage 3B, we don't do. It's an obliteration of the joint space. Infection, acute or chronic, peripheral occlusive vascular diseases. We have non-compliance, bad bones of tissue qualities. Relative contraindication, if you look at the literature, age plays a role. Is there a sharp edge kind of? I don't think so, but it can be question mark if this should be done, this technique, in patients that are older than 70 years. Smokers and older patients, especially this combination, you have also to be like with open eyes and say maybe this is not the right patient to do this technique on. Other contraindication, non-reconstructible hindfoot instability. If you have a ligamentous instability, you cannot treat or stabilize in your operation, you can't do it. If you have an osseous, of course, same thing, subtalar Chopard joint line. Pain at rest is a sign of a very a higher stage, maybe 3B, 4, so, cover to treat these ones. Mobility of the joint below 30 degrees, especially the group of Hintermann said, there is no improvement that can be expected with supramalleolar osteotomy. So mobility also plays a role in, of course, doing this. How is our radiographic assessment? We do these series of 4, we call it. It's like a dorsoplantar, sagittal, ankle-centered, Saltzman view, and an ankle AP mortise. And of course, we also do like a long leg weight-bearing X-ray, because as you can see here, sometimes you have to treat other deformities before you do the ankle. So we have seldom, but sometimes, the femur has an osteotomy and then we do it secondarily, or sometimes, but this is very seldom. We do it combined with a femur and a tibia osteotomy. But you have to keep this in mind, and I think this long leg weight-bearing X-rays are very important to plan. Another radiographic assessment, as normal in foot and ankle surgery, is an MRI for soft tissue, cartilage, if you have to combine some techniques here. A SPECT CT, which is also a possibility to really see osteostructures, neighboring joints, maybe that show activity, and also have some painful joints in the foot we cannot see on the X-ray. And of course, if you have the luxury of having a weight-bearing CT, I think this is excellent. And of course, this is very great for planning. Otherwise, you do it, for example, also with a CT. So radiographic assessment, it's important. You can see here, and I think this is how we do it and measure it. We can see this here, 8 centimeters above the tibia joint line, and 30. You do the circle, and then you put and measure your ankles. So what are the neutral aligned ankles? So what are we aiming for actually? So it's like the medial distal tibial angle, also as I said, the already medial distal articular angle. That should be around 92, 93. It's a little bit, you can see here, plus minus 3.2 degrees. Then we have the talar tilt angle, which plays a role. Yeah, the normal one is below 4. Then we have the tibio-talar surface angle. And we have the tibial lateral surface angle. I think these are the angles you need in order to plan this thing. So maybe to get you a little bit through this here, this is just a formula, how you can calculate it. And I just make it short, but I will show you actually. The rule of thumb, which is very important in orthopedic surgery, it's, as you can see here, if you correct 0.8 millimeters, you have a correction of 1 degree. So this is about, what to be expected. So if you look now on this picture out of this publication of Alexei Bach here, I think it's very nicely shown here. It's a weight-bearing mortise view. We measure the width of the distal part of the tibia. in this case is 54 millimeters. And then we have a supramalleolar valgus deformity, in this case is 5.5 degrees. Then we measure the medial distal tibial angle, which is in this case 95.5 degrees. And then we have alpha 1 amount of valgus deformity with desired overcorrection. So what overcorrection are we aiming for? It's between 2 to 5 degrees. In this case, it would be 5.5, as I said there, with alpha above here. You can see this here. And then we aim for like a 2-degree overcorrection. That means we would like to correct 7.5 degrees. So the height of the ridge we are planning to remove in this case would be then 7.5 times 55 millimeters, that ends up in a correction of 7 millimeters, which is also combined with our rule of thumb comes out to the same results here. So where to aim for? There are some publications in the beginning, they aim for like a correction always to 98 degrees, for example. Yeah, so, but the results weren't that good. And we are in our foot and ankle surgery journal we have of our EFA society here. They came out in June 22 here, this publication, and there's not really an optimal degree of correction. But what can we say? There is probably no effect if we correct more than 4 degrees. And of course, as more degrees you are correcting, you have to deal with translation and subfibular impingement. Especially if you go over 5 degrees or 6 degrees, you will see how much translation and subfibular impingement problems you will get. So there something between 2 and 4 degrees overcorrection seems to make sense for this technique. Now we're looking at the varus deformity. As I said, this is our majority of cases we have in Hanover. So there are like different techniques how we can address this deformity in our distal tibia. There is a medial opening ridge, and the indication is if we have a varus deformity below 10 degrees. If we have a medial distal tibial articular angle between 82 and 92 degrees, the aim is an overcorrection between 2 to 5. And that ends with a medial distal tibial angle of 94 to 97. So this is, if you have a varus deformity below 10 degrees. When do we do a lateral closing ridge? We do if the varus deformity is over 10 degrees. So why we're doing this? Of course, the medial approach is very easy. You can really nicely put your plate, you do your correction, yeah, and of course, skin tension and closure is important. If you are opening medial-wise more and more and more, you get more tension on your soft tissues, and that can give you really soft tissue problems on your medial side. So if you have to deal with a correction or like a varus over 10 degrees, you really should take into account doing a lateral closing ridge, because that doesn't give you this problems, and you don't want to have these experience that you after 3 months looking on your plate through the skin or without any skin on top of this. If we have a varus degree over 15 degrees or even more, because there are some patients with a lot of varus deformity, then you should consider a dome osteotomy to really deal with your translation accordingly. And the aims, of course, is always the same in overcorrection and also the ankle we would like to do so. So I would like to say, before I give over to Christian, what are our varus angle treatment options or menu we select something of? Yeah, as we said in the middle, you can see here, we can do a medial opening ridge with and without fibular osteotomy. Christian will talk about it. We can do a lateral closing, we can do a dome. I mean, we have, as I said, this depends a little bit on your primary deformity. But in addition, we can do a deltoid release, medial calectomy, lateral medial ligament reconstruction. We do a Dwyer calcaneal sliding osteotomy, especially in varus cases, a Dwyer. Dorsal extension osteotomy of the metatarsal 1, PL, PB tendon transfer. And of course, what we like to avoid is our orthodesis and arthroplasty, but maybe later on, 10 years or even more, then we have to add this procedure. So thank you very much until this point, and I give over to Christian, and he will continue and showing you some cases. Thanks for listening.
Thank you so much, Christina. If you can stop sharing.
I do. Should be.
Thank you so much. That was a very comprehensive and thorough talk about how to plan and the indications. And yeah, no, I'm sure there will be questions following when we start the discussion. I'm now going to invite our next speaker, Christian Plaas. He is our colleague in the European Foot and Ankle Society Scientific Committee. He is the chief editor of the German Foot and Ankle Journal. He's also a senior surgeon in Hanover Medical School, and he is the Congress president next year for the German Foot and Ankle Society meeting 2024 along with Austria. He has done a lot of research, publications, and he is going to talk to us about how to perform supramalleolar osteotomy. Over to you, Christian.
Yeah, thank you, Maneesh, for the invitation today. Thank you to the BOFAS for the possibility to speak here tonight about supramalleolar osteotomy. This is something that's followed by me for 15 years now, which I learned from Beat Hintermann. And I would like to show you some cases and how to do it in the practice. So here's my disclosure. And I would like to start with some various cases. You see here, first case, it's a 40-year-old male with a lateral ankle instability and also a little plantar pain in the first metatarsal. And you see here on the ankle AP view, the talar tilt, the contact of the medial ankle. And so it's Takakura 3A to 3B, and you also see here the hindfoot varus. Now, what possibilities do we have? You already seen that in Christina's talk. We have the possibility to do a medial open wedge osteotomy if we want to correct less than 10 degrees, a lateral closing wedge if we want to make larger correction, additional calcaneal osteotomies, ligament releases and ligament reconstructions, tendon transfers, and extension osteotomies of the first metatarsal. According to the planning and according to what we saw before, we planned this case and we wanted to do a 6 mm tibial correction and a 7 mm calcaneal correction. And now you see here the result. We did this osteotomy right on top of the syndesmosis. And as you can see here, we regularly use a hinge screw to protect the lateral hinge. You know from other studies, or we know from some studies, that if the lateral hinge cracks, that the results can be hampered. And we also know that even if it's not cracks intra-operatively, it can crack or get unstable during the healing phase. And with the screw, you can prevent this, and the rehabilitation time is shorter. And you can see nicely here how the weight-bearing axis is corrected from a varus to a neutral form. This is what you are aiming at. So what from our menu we did the medial chilectomies, we did the ligament reconstructions, we did the supramalleolar osteotomy, and we did the calcaneal osteotomy. When we talk about tibial osteotomies, we also have to discuss on which height we do this. You know from our book, we all know from Paley, the higher you get away from your joint line, the more translation you get on the height of a joint. And this is something you want to avoid. So you want to go as close to the joint as possible. But on the ankle, you have also the syndesmosis, and this is a quite sensitive area. So also have to think about this area. So we tend to go above the syndesmosis. I have some problems here. I hope you still hear me. When you look on it scientifically, you see here that if you go more distal, it's more stable. But as I said, the risk of a syndesmosic injury is higher. Another case, now you have a 57-year-old female. She has a tibia fracture 20 years ago, and she has increased ankle pain. The talonavicular arthritis was not symptomatic. And here again, you see the angulation of the distal tibia. And here we did an open wedge osteotomy again of the distal tibia. Here no hinge screw because it was stable, and then an fibular osteotomy. From our menu, we just did the supramalleolar osteotomy. Now, I showed you one case with and one case without a fibular osteotomy. And this, we took out this case because it nicely shows you what it differs. Here you see first the aiming K-wires for the osteotomy, and you also see the aiming wire for the hinge screw. And you see here now how I do the osteotomy, and I open it up with chisels and then put in a spreader to for correction. I put in a bone graft, and then I put in the hinge screw to protect the lateral hinge. And then I put on my medial plate. But what you also see on this X-ray is that I'm not completely happy with the position of the talus within the malleolus. You see here there's still some talar tilt, and especially when you're intraoperative, you feel that the talus is not following your osteotomy, but the fibula hinders it from turning. And then you see that I went on for a fibular osteotomy, and you see here's a difference between the X-rays without and with the fibular osteotomy, how the talus follows the fibula after the correction. And this is also analyzed in some publications. Here you see one of them from Liang from 2021, and he looked at their patients with and without fibular osteotomy, and they found that if you correct too much without a fibular osteotomy, you get impingement, or as you can see here, widening of the syndesmosis and pain and in the syndesmosis. This did not show in this follow-up study in the clinical parameters, but you see clear, better results in the radiographic results. In 2011, Markus Knupp and Schulz Dufkens published this biomechanical study analyzing the role of the fibula in stabilizing of the osteotomy. You see here, this is a neutral position. This is what you expect. You open up the tibia on the medial side, you produce a valgus, you move the weight-bearing axis to the lateral, and you expect the pressure line also go to the lateral. But what they measured was that it goes medially. And this is because the fibula hinders the talus from going lateral and to follow the tibia osteotomy. As you can see here, this is the result of the combined procedure of the tibia and fibula osteotomy. Here's another case. This is a 50-year-old male patient. He had a simple supination trauma, or it was not that simple because he had a osteochondral lesion. He had some kind of syndesmotic injury. He had a lateral injury, or a ligament injury, sorry. And he had this fixed in 3 operations, but he was not pain-free. He was not able to work. And this was the X-ray when we first met him. As you see here, he has this beginning varus ankle arthritis. And this was the first case when we started to ask ourselves, why don't we exactly know how far we have to correct our patients? You see here the slide from Christina, which showed that we have no exact data how much we should correct. And for me, a very important sentence from this paper is that it says preoperative analysis uses unreliable 2D alignment measures. And this is something important for me. We've got one other study from Haraguchi from the JBJS 2015 who showed then when you do I call it the weight-bearing Colsmann, so you do a full length posterior weight-bearing axis, you get really values which correlate with the clinical results. So perhaps it's not that there's not a correlation, but we measure it wrong. And since then, we started to measure all our patients on the CT. And I will show you here one patient, for example, what difference you measure in the CT analysis and on the radiographic analysis. And what we learn, what we feel is that the CT analysis with 3D reconstruction really gives more reliable angles than the 2D radiographic results. You see here the example of the same patient. You see here negative tibia tilt, which we thought we have to correct. And you see here the CT analysis, and you see that this is quite a normal slope, and there was nothing we had to correct. This also accounts for the valgus position of the ankle. So this is the CT analysis of the patient I showed you before. You get a nice, really reliable analysis of the leg axis, and then you can plan this also on the computer, how far you have to correct, and this really makes the operation quite easy. In this patient, we also did cartilage repair. You can argue that the literature says you don't have to do it because cartilage or some kind of tissue regenerates after unloading the joint. We do this in patients with localized cartilage lesions. We still do cartilage repair, not in patients with a classical arthritis. Here they get this is a hyalofast membrane for stimulation of cartilage restoration. And here you see now the cutting guide, which comes with a 3D printed tibia to know where exactly you go. And you see here's interruptive X-rays, the interruptive pictures, and how nicely you can correct this and then put in some autologous bone graft to fill up the gap. Here's the X-ray of this patient, and he's really happy. He started jogging again. Remember, he was not able to work before, and he is now nearly complete pain-free. So this is very good and very reliable procedure in these cases. Another patient, shown you also the lateral closing osteotomies. Here you see a patient with a flat foot combination, and here you see the example of lateral closing osteotomy. Myself, I try a little bit to avoid it because it's more traumatic, but there are really good indications to do so. And here you see how nicely you can correct the deformity also with a lateral closing wedge fibula and tibia osteotomy. You just get in from the lateral side, plan your corrections before, place your K-wires, do the osteotomy of the fibula like I said before, then you can also push it away and have a nice, can nicely approach the tibia. Here, the X-rays. This is a very special patient I want to present you now. This is an aunt of a colleague of ours. She had several ankle distortions. You see here this 3B Takakura arthritis. And when we saw her, she was quite okay. She said, I just have pain at walking. But then she said, no, I want to operate in about 1 year. And after this year, she came and she said, now I have pain at rest and pain at night. And we told her that it's probably not such a good idea to get with this kind of deformity still the correction. But she said, oh, let's try it. I'm willing to undertake this operation. And what's so special about this case, or it's not special, it's quite often that you have here this so-called zigzag deformity. So you have a varus tilt of the talus, and this is not only a varus tilt, it's also an anterior tilt, and you have this valgus tilt of the subtalar joint. Here you see the interruptive situs, and here you see the correction. But what you also see is that with this osteotomy, you still have here this talar tilt, and you also see that the calcaneus is still into valgus. And this is what happens in this situation. And you have to remember that if you treat these patients, when you have these peritalar instability and you put the calcaneus into valgus, you get a more rotational force on the talus, and you end up with even more varus position of the talus. So what you have to do in these patients, you have to stabilize them inframalleolar with a subtalar fusion to get rid of this rotational force, and also do your soft tissues realignment and your tendon transfers, and then you get a nicely balanced joint. The next lesson we can learn from this patient is that even if you cannot completely correct the talar tilt, as you can see here, is that this patient, we followed her very closely because I saw this colleague then every day. He always told me what his aunt is doing. She was 7 years completely pain-free. This is not what we promised the patient, but in her it was the case. And then from one day to the other, she got pain, and then we went on for arthrodesis because she wanted it. So this is also proven by literature that when you have more severe cases, you do not always gain a complete correction of the talar tilt, but the patients are still pain free or have less pain. The other thing we can think of, and Christina already told about that, is when you have more severe cases with the Takakura 3B, that you can do combined osteotomies of the median malleolus and supramalleolar. This is, for me, reserved to some special cases. As you can hear again, you combine intra-articular osteotomy of the median malleolus with a super syndesmotic osteotomy, and then you can correct the rotational position of the talus together with the weight-bearing axis of the foot, and then you also can reconstruct these severe patients. Another patient, 60-year-old with multiple sprains. And this is also something you have to think of. You're not only treating the ankle. So what we did here was a supramalleolar osteotomy, also with a fibular osteotomy. And I was quite optimistic that this patient would have a lot of profit from this operation. But you see here over the time that he rotates back into this varus position, and he said he didn't benefit so much from the operation. And this is another problem you can face, is that you also have the subtalar joint, and you can see here that the axis is not completely reconstructed as I thought it would be intraoperatively. And you have to remember that the subtalar joint can correct and negative influence your supramalleolar correction, especially in this varus ankles. That's something you have to consider. Then come to the valgus cases. Christina already showed you, depending on the patients you have. If you have post-fracture cases, you have more valgus cases. You have their fibular shortening, for example. You have a joint depression on the lateral side, but you also have patients with a flat foot deformity, which come with a valgus arthritis, or you have patients like here with a growing arrest or injuries of the epiphysis during growing and ending up in this valgus position. And then you have also the same possibilities to correcting them. You have similar pathologies. You can do here medial closing wedge tibia osteotomy, medial sliding calcaneal osteotomy, lateral calcaneal lengthening osteotomy, and all the other things you have to do. So you see here one patient, you see here this OCL on the lateral side. You see he already had an flat foot reconstruction. So from all the possibilities we have, medial closing wedge osteotomy was performed. You see here the wedge which was taken out. You see here the plate and the compression forceps, which was you do the correction. Here the interruptive pictures, and here the results 3 months postoperative. You see the nice unloading of the pathologic lateral side of the talus. Another case, fibular osteotomy, not fibular fracture and the syndesmotic injury, very fast developing this valgus deformity and this valgus arthritis. And here you see the correction, see the tibia osteotomy, but what is also of very important that you correct and lengthen the fibula in this case is to get the physiological length and to have the talus, as I showed you, stabilized within the ankle joint. Here you see the postoperative results and the nice reconstruction of the syndesmosis and of the ankle. Then last, what other pathologies we have to think of? It's not only the sagittal pathologies, it's also the frontal pathologies. Something we have very good results with our club feet. As you can see here, the typical patient is midfoot overloading due to pathologic flat top talus in a club foot. And here you can do a nicely closing wedge frontal osteotomy to allow a better dorsal extension of the ankle and this unloading the midfoot. The next dimension we have to think of course, there's something else, and this is something I would like to show you, because if you miss it, it can be a problem. You see here this 18-year-old girl with this varus deformity, and this was not a typical varus foot. When you took it in your hand, you said, that's different. You see also it has not typical the plantar flexed first ray. But when you looked at the radiographs, you see here this distortion of the Chopin line and the hindfoot varus, and she really had problems. She was supinating every day, and again, this is how she's walking, and this is how she's walking after we analyzed her, and you see here now the foot looks quite normal. Now, what is the answer? The answer is she had, here you see also the X-ray after physiotherapy. What she had was an excessive external torsion of the tibia, and she wanted to walk straight, so she turned the feet in, and this made her have a functional varus. If you miss this, what I did, you end up like this. This is also a young woman. She also had problems. She was always supinating. She had a progressive instability, and because of her varus deformity, I did only soft tissue procedures. But as you can see here, this ended up in the plantar valgus feet. And so with a 34-year-old girl, we had to do a derotational osteotomy and the arthrodesis. If you see these cases and get them right, you see here, as seen here, by derotation, you get a nice correction of the foot and have a good result. For severe cases, as here, you can also pre-plan this. Yes, this is my last case. I'll finish now. Pre-plan this nicely in the computer, and then you do a dome osteotomy to avoid translation. And here you can see that you can also get severe deformities corrected by this. So the lessons we learned from the supramalleolar osteotomies, it is an alternative for asymmetric ankle osteoarthritis. It saves the joint, it reduces progression of ankle arthritis, it keeps mobility, and it buys time for total ankle arthrodesis or replacement. It's an indication, it has indications for opening, closing, and dome-shaped osteotomies. It is only a part of your hindfoot correction, and preoperative planning is important. Thank you.
Thank you so much, Christian. That was such a lovely talk. You gave so many examples, and I wish we could have carried on, but I think we audience want to ask some questions, so we need to give them a chance for discussion. So I've got a few questions here. So first of all, Christina, you talked about the longevity of this procedure at 5 years to be about 88%, 87 point something. How about 10 years, 15 years? Because patient is interested more in terms of how long the effect of the operation will last for.
Yeah, there's a variation there, of course, by over 3 years. So it could be also, they had results, good results over 12 years for some patients follow-up. Yeah. They looked at the data in this publication from Beat Hintermann starting 1999 until 2013. So there were patients over 10 years having good results with this technique. Yeah, but that was the average 5-year follow-up that they have there. So, but there are examples of 10 years, 12 years. But I think we have really to tell, as the same with tibial, high tibial osteotomies. It's a time-saving procedure, and you cannot promise this will be the last procedure you get. Yeah, there can be arthrodesis or prosthesis afterwards. I think, Christina and myself, we tell them 5 to 10 years. That's the option we can gain. Some people I have patients with 15 years. Yeah.
Excellent. The second question is anecdotal and based on previous studies. Is there any study which correlates clinical outcome versus radiological outcome? Because some people say that X-rays might not look very good after 7 years, but clinically the patient is doing well. What do you think, both of you, Christian and Christina?
Yeah, I think it's for sometimes it's like minimal invasive surgery. You think, I mean, how are the bones looking in your X-rays can be satisfying for the patient, but this is not. I mean, it correlates to a certain point, of course. Yeah, but there are cases, as Christian showed one case today, didn't look great, but had 7 years no pain at all. Yeah, and was very, very satisfied. Some people can do sports again, and of course, sometimes it's not totally and 100% correct, but they have still very good clinical outcome.
And Christian, you would agree to that?
I completely agree, yes.
Excellent. Thank you. Christian, I was interested in your technique about hinge screw. I mean, I've done osteotomies just using the plate, but you think the additional screw provides more stability and you can get them walking faster without plaster boot?
We've tried several plates and we noticed that that the patients profit from a very stable osteocentesis. They have less swelling, less pain in the postoperative phase. And then I still had some patients which showed callus on the lateral side. And then since I use this hinge screw, I don't have this issue anymore. So I feel very safe with this hinge screw, and I do it no matter if it cracks or if it not cracks, I always put it in there.
Thank you. So I have two questions about the peri and post-operative. So bone graft for opening varus osteotomy, I've seen, like your example showed that you moved again, you've tried different things. So is that right? And what do you use these days?
We use bone graft in all cases. I don't know if it's necessary, but the distal tibia is more not as forgiving as the proximal tibia. And we use a so-called tutoplast, which is made from a femoral head.
Okay. And what is your post-operative regime about after supramalleolar osteotomy? Plaster, boot, weight bearing?
So we just take a walker, like a it's a walker they use as splint for 2 weeks, non-weight bearing. After wound healing, 15 kilogram partial weight bearing in the walker for another 4 weeks, and then increasing over 4 to 6 weeks. So all over they have the boot between 10 and 12 weeks.
Up to 12 weeks.
Yeah, up to 12, 10 to 12.
Okay. There's a question here from one of the audience about plefonoplasty. I think you showed a picture which looked like plefonoplasty to me. So
yeah,
going into the joint.
Nowadays, I mean, we compete with total ankle replacement in these severe cases. And personally, I just did 1 or 2 of this plefonoplasty. Most of these patients are handled with arthrodesis or arthroplasty nowadays by me. If you have a younger patient, this might be an option. But in general, there's also a paper out saying that these patients get along better with arthrodesis. So this is reserved for, in my hands, for quite special patients.
Right. Thank you. And then there's another technical question. How do you protect the bone doesn't fracture, like, the lateral cortex, if you're doing the opening wedge? How do you protect it? I mean, obviously I've seen you using screw, but is there any other technical tip to see how much width you can take out before the bone fractures?
I think that's what Christian shows is like really slowly opening it and then opening it with this like 2 or 3 chisel technique. We do it and really, just do it. Don't do it too quickly and really, see how the effect is in to do it. And if it cracks, put the screw in. And as Christian said, maybe put the screw, as we say nowadays, always in there as a protection.
Great. Now, there's always been, fibular osteotomy, people are, bit concerned. So there are lots of questions about fibular osteotomy. Do you need to do it? And you've given the answer when to do it. Secondly, if you do it, do you worry about the height of the fibula? Do you just do the osteotomy, and do you put bone graft for fibula? What are tips about fibular osteotomy? How do you do it, and when do you do it?
I think the books about fibular osteotomy are not closed. I'm more aggressive with the fibular osteotomy than I was 5 years ago. I do it more and more, but I always do first the tibia osteotomy, fix the tibia, and then I do the fibular osteotomy, so you don't have an unstable ankle during the operation. And when you do then the fibular osteotomy, you can have different techniques how to do it. You can use a Z form. What I do, I just do a long cut like a Weber B fracture, exactly the same position, exactly the same side. And then you will see that the fibula and the talus shifts the fibula in the position where it, I say, belongs. If you have an valgus arthritis, you often have to shift the fibula distally and lengthen it, which you can do with a bone clamp. And in the varus patients, they just will follow the talus.
Thank you. Final questions. We have questions, but just to keep it in time, 2 questions. And Christian and Christina, you can decide, answer one each. So first question is about overcorrection. what are your thoughts about overcorrection? Can you do it? And if it's done, then what do you do? Does it lead into arthritis, fusion, replacement? So thoughts about overcorrection, any one of you?
When you look at the literature, you see that the overcorrection on conventional X-rays more than 4 to 5 degrees has no positive influence. So what we did 10 years ago, where we corrected 7, 8 degrees, this was, for me, was too much. We went now back to 3 to 4, 5 degrees overcorrection. So if you have to make it to a total ankle replacement or total ankle arthrodesis, you can easily correct this within the joints. You don't have to redo the corrective osteotomy. If you do not correct too much, it's possible to do that, and that's because the patients do not profit of an overcorrection. We don't do that anymore.
Thank you. And the final question is, how many procedures in addition to the osteotomy you can do in one sitting, like 2 hours tourniquet? So the person who is asking the question is asking, can you do subtalar fusion, supramalleolar osteotomy, ligament reconstruction, all that in one go, or how do you do it?
Yeah, I think this, I mean, you can do calcaneal osteotomies, you can do subtalar fusions, you can do ligament reconstruction, tenodesis, these soft tissue things you can do. What we don't do is don't do supramalleolar osteotomies, what some people do in Germany, and then put a arthroplasty in there. So like all these combinations. So we don't combine that. So we just do soft tissue reconstruction and calcaneal or subtalar fusions with supramalleolar osteotomies.
Excellent. I think that will bring us to the end of this excellent session. I really want to thank you both, Christian and Christina. That has been very useful for our audience. Over 100 people joined us for this webinar, and lots of them asked questions. So thanks to you both for giving, and please stay with us. We'll just have a debrief once we've finished it. Regarding our attendees, you will be receiving an email with a link for the feedback, and once you've done the feedback, you'll receive your certificate. So please try to give your feedback. It's always useful to plan our future webinars. Also, the next Master Techniques webinar is in 2024 in January. We'll announce the dates. If you have any burning ideas you would like us to bring speakers about a particular topic, please email us, and we'll be very happy to accommodate the majority of the people who want to listen to a particular topic. Thank you very much. Have a great evening, and we see you again in January for another Master Technique webinar from BOFAS. Have a great evening. Thank you.